for today's event. Today's educational web seminar is presented by LabRoots and brought to you by ARUP Laboratories. To learn more, visit bio-rad.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. As a reminder, this presentation is educational and offers free continuing education credits. Please click on the CE credit icons at the bottom of your screen and follow the link to obtain your credits. With that, I'd now like to welcome our speaker, Dr. Lisa Peterson, Associate Professor of Clinical Pathology at the University of Utah and Medical Director of Immunology, ARUP Laboratories. For a complete biography on our speaker, please click on the Presenter tab. Dr. Peterson, thank you for joining us. You may now begin your presentation.
Hello, and thank you for joining me today to discuss the differences between anti-RNP and anti-Smith RNP antibodies and the implication of these differences in the diagnosis of autoimmune disease. Before beginning, I have one financial relationship to disclose, which is that I am a member of WRFN's Scientific Advisory Committee. The learning objectives for this presentation are that after participating, you should be able to describe the role of U1 ribonucleoprotein or RNP antibodies in the diagnosis of mixed connective tissue disease, discuss the variety of antigens and methods used to detect RNP antibodies, and recognize differences that exist in how RNP antibody results are reported, which may lead to confusion. I would like to start with a case to set the stage for why we are discussing the differences between anti-RNP and anti-Smith RNP antibodies, and the potential impact of which of these tests is ordered and how the results are interpreted on the evaluation of a patient for autoimmune disease. A 44-year-old woman was experiencing joint pain and had developed a rash, so she scheduled an appointment with her primary care physician, who ordered testing for anti-nuclear antibodies, also known as ANA, by indirect immunofluorescence assay, and anti-RNP antibodies using a multiplex chemiluminescent assay. The patient was positive for anti-RNP antibodies, but negative for anti-nuclear antibodies by IFA, as well as double-stranded DNA antibodies, Smith antibodies, and rheumatoid factor. She was given an initial diagnosis of mixed connective tissue disease and treated with high-dose steroids, but her symptoms continued to worsen, with the rash spreading to involve her eyelids, chin, and both arms. She was referred to a rheumatologist, at which point she was reevaluated. The patient reported that her skin peels and then grows back. She had previously seen a dermatologist who noted that she had eczema. Over-the-counter steroids and eczema cream were found to reduce her symptoms. On examination by the rheumatologist, her skin appeared erythematous or red with scales. The patient denied having a rash involving her cheeks and did not have evidence of a malar rash on examination. The rash on her eyelids did raise the possibility of a heliotrope rash, but it was not scaly. The patient denied experiencing symptoms of Raynaud syndrome or color changes in her fingers. She had experienced muscle pain or myalgias, but upon examination, no weakness was noted. The rheumatologist ordered repeat testing to confirm the RNP positivity and evaluate for the presence of other antibodies. Results of repeat anti-RNP antibody testing were negative, as was testing for additional autoantibodies, including ANA by IFA, anti-Smith, anti-SSA52, anti-SSA60, anti-SSB, anti-double-stranded DNA, and an extended panel of autoantibodies associated with myositis. The physician called the laboratory to discuss the contradictory anti-RNP antibody results and whether this patient has mixed connective tissue disease. Before discussing the results of this case further, let me provide you some background on mixed connective tissue disease and RNP antibodies. Mixed connective tissue disease was first described in 1972 by Sharp et al. In a group of 25 patients whose sera contained a hemagglutinating antibody against an extractable nuclear antigen, or ENA, that consisted primarily of protein and RNA. Patients had high titer ANA with a speckled pattern, but none of them had detectable Smith antibodies, and antibodies to native double-stranded DNA were rare and of a low titer when present. Complement levels were elevated or normal in this group of patients, and clinically the patients demonstrated a combination of symptoms similar to those observed in systemic sclerosis, systemic lupus erythematosus, and myositis. And these patients were also found to be responsive to corticosteroids and to have a favorable prognosis. In both Sharp's original description as well as newer reviews on mixed connective tissue disease, the most frequently observed symptoms included arthritis, swollen hands or fingers, Raynaud's syndrome, and myositis. With the images on this slide depicting some of these symptoms, such as arthritis and swollen fingers or swollen hand, as well as additional symptoms that have been observed in mixed connective tissue disease patients, such as nail fold capillary changes and skin manifestations such as interface dermatitis and mechanic's hands. The manifestations of mixed connective tissue disease often develop sequentially over time. Inflammatory manifestations such as synovitis, myositis, and serositis are generally steroid responsive, decreasing in both frequency and severity upon treatment. The symptoms that persist tend to be those associated with systemic sclerosis, including esophageal dysmotility, sclerodactyly, and Raynaud's syndrome. Many patients experience what is called a clinical shift within 10 years of diagnosis, with 58% of those initially diagnosed with mixed connective tissue disease evolving to a diagnosis of systemic sclerosis, systemic lupus erythematosus, or rheumatoid arthritis. Pulmonary arterial hypertension is the primary cause of death in patients with mixed connective tissue disease, whereas life-threatening renal or central nervous system disease are rare in these patients. Serologically, patients with mixed connective tissue disease are characterized by the presence of high-titer anti-RNP antibodies. Several algorithms are available for the diagnosis of mixed connective tissue disease, which differ slightly in their serologic criteria, such as the requirement for a high-titer speckled ANA pattern and/or the lack of detectable anti-Smith or double-stranded DNA antibodies. They also differ in the symptoms that must versus may be present and the number of clinical features that must be present. But they all require the presence of high-titer anti-RNP antibodies. Distinguishing mixed connective tissue disease from other conditions with similar clinical features is crucial because they may differ in prognosis and response to treatment. To address the question of whether a patient has mixed connective tissue disease, it is important to understand U1-RNP and the antibodies which recognize it. The original description of mixed connective tissue disease included the presence of an antibody reacting with saline-soluble extracts of nuclei, termed extractable nuclear antigen, or ENA, that produced a speckled ANA pattern by immunofluorescence microscopy. At that time, the Smith antigen had been identified as an ENA specific for patients with systemic lupus erythematosus, and as a protease-sensitive protein contained within the ENA mixture. In contrast, the antigenic target of sera from patients with mixed connective tissue disease was shown to be an ENA whose antibody reactivity was both RNase and protease sensitive, which implied the antigen consisted of both RNA and protein, leading to the term ribonucleoprotein, or RNP antigen. U1-RNP is a small nuclear ribonucleoprotein consisting of U1 RNA and U1 specific proteins A, C, and 6870. U1-RNP is part of the nuclear speckle, where its functional role is to assist in splicing pre-messenger RNA to mature spliced RNA. As mentioned earlier, patients with mixed connective tissue disease form high titers of antibodies against U1-RNP, which in turn produces a high titer speckled ANA pattern. These antibodies are hypothesized to develop when a genetically predisposed individual mounts a specific immune response against a microbial antigen that cross-reacts with the U1 70 kilodalton protein. Although anti-RNP is an important serological marker for the diagnosis of mixed connective tissue disease, it can also be present in other forms of systemic autoimmune rheumatic diseases, including lupus, systemic sclerosis, undifferentiated connective tissue disease, myositis, and overlap syndromes. But anti-RNP usually occurs at lower titers in those diseases than the titers observed in mixed connective tissue disease. Early and accurate diagnosis of systemic autoimmune rheumatic diseases is challenging, owing to the wide, often overlapping spectrum of symptoms. Antibodies against both Smith and U1-RNP both target the U1-S1-RNP complex. However, in addition to binding the U1 complex, Smith antibodies also bind to the uridine-rich RNAs U2, U4, and U5. Whereas the U1-specific polypeptides A, C, and 6870 are specifically targeted by anti-RNP. Antibodies against RNP are thought to be against both discontinuous or conformational, as well as linear epitopes contained in the protein sequences themselves or present after post-translational modification. RNP antibodies can be detected and measured using a variety of antigens, as well as diverse types of solid phase immunoassays. Antibodies against the Smith RNP complex are typically detected using antigen that is isolated from animal tissue. They are not the same as the antibodies detected using RNP-specific proteins or Smith-specific proteins, but instead are antibodies to conformational or higher order structure of the U1-RNP complex formed by the combination of U1-RNP proteins, U1-RNA, and Smith proteins. Initial studies defining mixed connective tissue disease and the associated ENA U1-RNP used Octolani gel immunodiffusion, counter-immunoelectrophoresis, and hemagglutination. However, there are challenges and limitations to those methods, including lower sensitivity for the detection of anti-RNP antibodies in sera from patients with mixed connective tissue disease, subjectivity in result interpretation, the complexity of the performance of these methods, and the training required to achieve competency, especially in comparison to newer, less complex, and more easily automated methods. Thus, these methods have largely been replaced by more sensitive and less subjective assays, including enzyme-linked immunosorbent assays, ELISAs, immunoblots, and multiplex assays. The meaning of and terminology for RNP has evolved as understanding of autoantigens and the methods of detection have progressed. Currently, the RNP autoantigen associated with mixed connective tissue disease is variably described as RNP or U1-RNP, based on the U1 RNA found to be the RNA component, and is detected using cellular extracts such as those used for the detection of Smith RNP antibodies, or purified proteins, recombinant proteins, synthetic peptides, or dominant epitopes of the three main RNP proteins, 6870, A, and C, either singly or in various combinations, typically in the absence of RNA. Two general types of antigens are currently used to detect antibodies against RNP. Native tissue-derived U1 RNP complex, often referred to as smRNP, to clarify that both antigens are present as potential targets for autoantibodies, and U1 RNP specific proteins or peptides, such as RNP70, RNPA, and RNPC. Information about the specific amino acid sequences of the recombinant peptides or proteins is not readily available and may not be the same in all assays. If testing is performed using an assay that contains the Smith or smRNP antigen, testing for Smith antibodies is recommended to clarify whether the reactivity is specific for U1 RNP or is actually against the Smith antigen. Patients with systemic lupus erythematosus frequently have antibodies to both RNP and Smith, while patients with mixed connective tissue disease have antibodies to RNP in the absence of antibodies to Smith. The variety of antigens that can be used to detect RNP antibodies, in addition to the diverse types of solid phase immunoassays used to measure these antibodies, contributes to the confusion that exists regarding nomenclature, reporting, and interpretation of anti-RNP results. Naming of assays for detecting anti-RNP antibodies based on the source and/or combination of antigens included in the assay is not consistent. In recent years, there have been efforts to label assays that use the intact U1 RNP complex as smRNP or RNP/SM, and those that only contain the U1 RNP specific proteins or peptides as RNP. However, the number and specificity of the U1 RNP specific proteins or peptides included is not consistently present in the name of the assays. In addition, there may still be manufacturers or laboratories that use the intact complex, which also contains Smith proteins, but label the assay RNP. Lack of consensus between the results of these assays is not rare, and all the reasons for this non-consensus are still unclear. Thus, when interpreting results of testing for RNP antibodies, it's important to determine whether the antibodies being detected are against RNP-specific proteins or the Smith RNP complex, particularly when trying to determine if a patient's symptoms are due to an RNP-associated connective tissue disease. Several years ago, we conducted a study to evaluate the clinical impact of antibodies against the RNP-specific proteins, RNP68 and RNPA, versus antibodies against the Smith RNP complex in patients under clinical evaluation for mixed connective tissue disease or U1 RNP-associated connective tissue disease. We used 498 consecutive specimens from patients under evaluation at the University of Utah and tested them using two different multiplex assays. Any specimen which was positive for RNP antibodies using either of the assays was then tested again for antibodies against the Smith RNP complex using two additional assays. The results were evaluated for antibody positivity by analyte and method of detection, positive agreement, and the impact on clinical diagnoses through retrospective chart review for positive patients. All three of the assays that use the Smith RNP complex to detect RNP antibodies demonstrated equivalent performance in identifying patients with mixed connective tissue disease. In contrast, the assay that measured antibodies against the RNP68A was more sensitive but less specific. In addition, when antibodies against Smith RNP and RNP68A were measured using the same platform, they did not appear to have equivalent performance characteristics. This suggests that there are unique attributes of U1 RNP analytes in disease evaluation, and this has implications for reporting and interpretation of the results. The differences observed may be related to how the epitopes are expressed in the assays, the calibration of the different assays, or to factors relating to the patient populations used in the validation of the RNP68A and Smith RNP antibody assays. Thus, the specific analytes used in the detection of anti-RNP antibodies must be reported for appropriate utilization, interpretation, and comparison with results generated using other assays. With that in mind, let's go back to the case and answer the questions of, is it anti-RNP or is it anti-Smith RNP? And is it mixed connective tissue disease or is it not mixed connective tissue disease? These are the questions. For the 44-year-old woman with joint pain and a rash, although suspicious for connective tissue disease based on the location of the rash on the eyelids, given the presence of scale and the description of peeling skin, as well as the absence of Raynaud syndrome, which is present in most patients with mixed connective tissue disease, the rheumatologist ordered repeat testing for RNP antibodies. The repeat RNP antibody testing was performed at a different laboratory that used the Smith RNP complex as the antigen for detecting RNP antibodies. And in this case, the patient's results were negative. This patient's specimen was also tested on 2 additional assays that measure antibodies against Smith RNP and found to be negative using all 3 assays. Thus, the initial positive anti-RNP antibody result was likely due to the high sensitivity but poor specificity of the initial assay used to test for anti-RNP antibodies, which used the RNP68A antigen as the target for measuring those RNP antibodies. So does this patient have mixed connective tissue disease? Let's evaluate this using the proposed criteria for mixed connective tissue disease. The patient is positive for RNP antibodies by ELISA, although it's difficult to say whether she would have also been positive by hemagglutination or immunodiffusion assays. The patient is also negative for Smith antibodies, negative for double-stranded DNA antibodies, and other antibodies associated with connective tissue disease. She's also negative for ANA by IFA. In addition, she did not meet the clinical criteria for mixed connective tissue disease. So the answer to the question of whether this patient has mixed connective tissue disease is no. The patient's results do not support a diagnosis of mixed connective tissue disease. Thus, the patient was weaned off prednisone and referred to dermatology under the suspicion of eczema. But this is just one case. Let's take a look at a few more. Case 2 involves a 64-year-old woman who developed photosensitivity, alopecia or hair loss, dry eyes and dry mouth, and joint and foot pain. She had been diagnosed with Sjogren's syndrome 32 years earlier based on sicca, tooth decay, swelling of her parotid glands, and serologic testing. 10 years later, she was diagnosed with systemic lupus erythematosus and rheumatoid arthritis based on laboratory results. She presented to her primary care physician recently and was tested for antibodies against SSA52, SSA60, and RNP, and was found to be positive for all 3. She was referred to Rheumatology for follow-up of Sjogren's syndrome lupus overlap. Repeat RNP testing Using an assay that used the Smith RNP complex was negative, but testing for additional autoantibodies, including ANA by IFA, anti-Smith, anti-SSA52, anti-SSA60, anti-SSB, and anti-double-stranded DNA antibodies were all positive. Again, the initial positive anti-RNP result was likely due to the high sensitivity but poor specificity of the initial assay used to test for anti-RNP antibodies, which was the one that included the RNP-specific proteins 68 and A. This patient was one of 2 connective tissue disease patients in the 2023 studies that were positive using the RNP68 antibody assay, but negative by all 3 Smith RNP antibody assays. Use of the proposed criteria for mixed connective tissue disease demonstrates that this patient is positive for RNP antibodies by ELISA, although similar to what we had discussed for the first patient, it's difficult to say whether they would have also been positive by hemagglutination or gel immunodiffusion. Different than the previous patient, this patient is also positive for high titer speckled ANA, as well as double-stranded DNA antibodies and other antibodies associated with systemic lupus erythematosus and or Sjogren's syndrome, although she is negative for Smith antibodies. In addition, she did not meet the clinical criteria for mixed connective tissue disease. Taken together, these results did not support a diagnosis of mixed connective tissue disease. The initial anti-RNP68A antibody result was considered false positive since anti-double-stranded DNA antibodies were positive and the patient's clinical features were more consistent with Sjogren's syndrome and lupus. Our final case involves a 22-year-old woman who developed worsening pain, stiffness, discoloration, or cyanosis in her hands, and changes in the appearance of the skin on her hands and forearms. She was also experiencing additional symptoms such as esophageal dysfunction, sclerodactyly, and salivary disease. Her previous laboratory results were positive for rheumatoid factor and RNP antibodies, as well as persistently high inflammatory markers. She presented to the rheumatology clinic for follow-up and requesting treatment be initiated at this point. Repeat anti-RNP testing was positive, as was testing for ANA by IFA. Anti-SSA52 and anti-SSA60 antibodies were also positive. The results of testing for additional autoantibodies, including anti-Smith, anti-double-stranded DNA, anti-SCL70, anti-RNA polymerase III, and an extended panel of myositis antibodies were all negative. Using the proposed criteria for mixed connective tissue disease demonstrates that, again, this patient is positive for RNP antibodies by ELISA, but it's difficult to say whether they would have been positive by hemagglutination or gel immunodiffusion. Additionally, this patient is positive for high titer speckled ANA and negative for Smith double-stranded DNA antibodies, as well as for most other antibodies associated with connective tissue diseases, except for antibodies against SSA52 and SSA60. Thus meeting all of the proposed serologic criteria for mixed connective tissue disease. With regard to the clinical criteria, although she does not meet the Alarcon-Segovia clinical criteria due to the lack of symptoms of myositis, she meets the other 3 sets of proposed criteria. So does this patient have mixed connective tissue disease? Yes, this patient was diagnosed with mixed connective tissue disease and Sjogren's syndrome. Treatment with high-dose steroids was initiated and her symptoms improved. Multiple challenges exist with regard to testing for antibodies to UNRNP. some of which have been discussed earlier in this presentation. With regard to standardization, some of the challenges associated with testing for antibodies to U1-RNP include the lack of international standards for the different antigen preparations, known differences in antigens and/or methods used, issues with transparency and/or access to information regarding the source of antigens used, and differences in terminology used. All of these issues could impact assay validations or evaluations, such as those performed to assess proficiency, whose success may differ based on the predicate assay used. Those challenges all relate to the technical aspects of RNP antibody testing. But another important consideration or challenge related to standardization in this area is the absence of established consensus criteria for mixed connective tissue disease. As a laboratorian and a Ph.D., I cannot comment on the clinical aspects of the criteria, but I do have some suggestions on the laboratory or serologic criteria that I think should be evaluated further to determine the specifics of each aspect. The presence of RNP antibodies has been and should remain part of the criteria, but further studies are needed to establish which antigens should be tested for and the titers of the respective antibodies associated with a diagnosis of mixed connective tissue disease. A high titer speckled ANA was part of the original criteria, and its inclusion is likely to improve the specificity of future criteria. Similarly, the lack of Smith and negative or low titer double-stranded DNA antibodies were part of the original description of mixed connective tissue disease, and further studies should be conducted to evaluate whether low or borderline results for these antibodies should preclude a diagnosis of mixed connective tissue disease. Of note, a few years ago at the International Congress on Autoimmunity in Athens, Greece in 2022, Dr. Mark Werner of the University of Washington proposed new serologic criteria for mixed connective tissue disease, which included these recommendations with an additional specification that the titer of speckled ANA required be greater than the population-based 99th percentile, determined using a healthy control population. Although, as mentioned on the previous slide, additional studies are required before more specific criteria can be defined. In addition to the new serologic criteria proposed for mixed connective tissue disease, an additional recommendation for addressing the challenges associated with interpreting the results of RNP testing is the combined interpretation of results of testing for antibodies against Smith on its own, the Smith RNP complex, and RNP-specific proteins, as well as ANA by IFA, where a combination of positivity for Smith RNP antibodies in combination with a high titer speckled ANA and negative, low, or borderline results for Smith antibody is associated with a diagnosis of mixed connective tissue disease, regardless of whether antibodies to the RNP-specific proteins are present. Whereas the lack of a high titer speckled ANA would change the interpretation to a non-mixed connective tissue disease specific finding. In contrast, a high positive result for Smith antibodies and a high titer speckled ANA is associated with a diagnosis of systemic lupus erythematosus, regardless of whether antibodies to RNP-specific proteins or Smith RNP complex are present. Based on our current knowledge, a high positive result for RNP-specific proteins in the absence of high positive Smith RNP antibodies, but with a high positive speckled ANA titer, should lead one to consider mixed connective tissue disease. But a high positive result for RNP-specific proteins in the absence of a high titered speckled ANA is not considered consistent with a diagnosis of mixed connective tissue disease. With regard to education, some of the challenges associated with testing for antibodies to U1-RNP include the lack of awareness about the differences that exist between assays for detecting U1-RNP antibodies. This is a gap which I hope this presentation is helping to address, and I hope that you will assist me with addressing this by sharing this information with both your laboratory and clinical colleagues. In addition, there is a lack of awareness about specific antigens used in the assay being ordered. I would like to challenge each of you to help in addressing this issue by determining which antigens are used in the assays offered by your laboratory and whether that information is easily available. And if not, reaching out to your laboratory about making it available. There are also regulatory challenges associated with testing for antibodies to U1-RNP, including the possibility that a lack of knowledge or consideration of the antigenic specificity in the predicate assay used for assay validation may pose challenges for meeting regulatory requirements. Or the differences in the antigens used may cause challenges with performance on proficiency testing. These issues beg the question of whether regulations are needed to require transparency regarding the antigens used for the detection of autoantibodies. Another challenge associated with testing for antibodies to U1-RNP is whether patients should be tested for other connective tissue disease-associated antibodies, since they may be positive for those other antibodies, which may result in them meeting the criteria for another connective tissue disease other than mixed connective tissue disease. In summary, identification of anti-U1-RNP specific antibodies is useful for both diagnosing mixed connective tissue disease and predicting or monitoring the development of additional clinical manifestations. Variability exists regarding both the analytes and the methods used to detect anti-U1-RNP specific antibodies, as well as the nomenclature used. Thus, anti-RNP antibody assays do not always yield the same results. These seemingly discrepant results are complex and confusing for both laboratorians and clinicians to interpret, as well as for comparisons between assays for validation or quality assurance purposes. Although anti-RNP antibodies were used as the example for this case, similar issues exist for other autoantibodies. Clinicians and laboratorians need to be familiar with these challenges, and laboratories should specify the antigen or antigens used in their assays to aid in test utilization, comparisons between assays, and interpretation of the results. And finally, collaboration and communication between clinicians and laboratorians is essential for optimal utilization and interpretation of these assays. There are a number of opportunities for improvement and next steps for those of us working in this field, and I would like to make this a call to action for those joining today as well as those listening to the recording at a later date. Vendors and laboratories need to specify which analyte is used when reporting results for RNP-specific proteins versus the Smith RNP complex antibodies. Again, I want to encourage each of you to determine which of these tests is being used by your local laboratory and if the specificity of the antigen used is readily available. Additional collaborations are needed between vendors and laboratories to educate clinicians on the differences that exist between assays available for the detection of RNP-specific proteins versus Smith RNP complex antibodies, such as the one we are all participating in today. In addition, the serologic portion of the mixed connective tissue disease criteria needs to be updated to include detection of anti-RNP specific proteins as well as anti-Smith RNP antibodies using current methods. They should also be updated to include the presence of a high titer speckled ANA and negative, low, or borderline results for anti-Smith and/or anti-double-stranded DNA antibodies. However, there are further studies needed using the current assays to establish which titers or levels of antibody are required for a diagnosis of mixed connective tissue disease, or if presence of Smith or anti-double-stranded DNA precludes a diagnosis of mixed connective tissue disease. Finally, additional investigations are needed to determine the clinical significance of positive results for RNP-specific antibodies in patients without evidence of connective tissue disease, particularly when they are above a certain level and/or if the ANA is positive at a high titer. I would like to conclude my presentation by acknowledging my collaborators on the 2023 study, in which we compared the clinical associations of antibodies against RNP-specific proteins and the Smith RNP complex. I would also like to acknowledge and thank Dr. Mark Werner, who graciously shared several of the slides as well as some of the content on the slides that I presented today. Thank you again for joining me today, and I would be happy to take any questions that you may have at this time.
All right. Well, thank you so much, Dr. Peterson, for your informative presentation. We will now start the live Q&A portion of the webinar. So to our audience, if you have a question that you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. All right, so let's get started. We've got some great questions coming in here. Dr. Peterson, my first question for you asks, what is the clinical utility of positive anti-RNPA in isolation? Our lab sees many patients with positive RNPA antibody in isolation without clinical features of CTD.
Thank you very much for that question. That is an area of active investigation. As I mentioned, one of my last next steps was exactly this. We need further investigation into what the significance of these antibodies is, because similar to what this participant reported, we saw quite a few of these results in our Archives of Pathology study in 2023. So I can't give you an answer today, but I hope to be able to look into it further soon.
Great, thank you, Lisa. All right, next question here. What is the specific antibody to test MCD?
So currently, using the current methods, both assays that detect RNP-specific proteins like RNP68 and RNPA, as well as assays that use Smith RNP as the antigen to detect the antibodies are sensitive for detecting patients with mixed connective tissue disease. However, the RNP-specific protein assays have been found to have issues with specificity. So the most specific assay that can be used at this point for mixed connective tissue disease are assays against the Smith RNP complex.
Great, thank you. All right, another question for you. What about looking for antibodies for U2 or U3 RNP? Do these need to be included in some panels?
I think it really depends on the exact symptoms the patient is exhibiting. U3 RNP tends to be more associated with systemic sclerosis, whereas U2, in my experience, is more associated with myositis, but also often coexists with U1. I would say, from my opinion, at this point, I don't think that they need to be included in a panel, that all patients being tested for mixed connective tissue disease would be tested for, but it really depends on the symptoms being exhibited by each individual patient, whether U2 and U3 should be included.
Great, thank you. All right, I have another question here. We currently perform the Werfen SM and SM RNP ELISA tests and report these results together. A comment is also put that, in that states, when interpreting the SM RNP result, you should take into consideration the SM only result. Is this sufficient? Or should we also perform the U1 RNP test?
I think in most cases, this is sufficient, and this is actually what I do or what my laboratory does. However, there may be specific cases in which those tests come back negative and there's a very high clinical suspicion, in which consideration of whether the patient has a high titered speckled ANA pattern along with antibodies to RNP specific proteins that may be able to support a diagnosis in certain patients.
Great, thank you. Now, is anti-RNP positive not necessarily anti-SMRNP also positive? What is the percentage of anti-RNP and anti-SMRNP double positives and total anti-RNP positives?
All right. I will say this is another area in which I hope to have the opportunity to do further investigation. In our study, what we found was of 47 patients that were positive for RNP or antibodies against RNP specific proteins, only 1/3 of those were also positive for antibodies against the Smith RNP complex. And so positivity for RNP using an antibody or an assay that detects antibodies against RNP specific proteins does not necessarily equal positivity for the Smith RNP complex antibodies.
Great, thank you. All right. Now, do you think these tests should be repeated frequently since most autoimmune diseases are monitored for several months or even years?
At this point, I don't know that there's any evidence that RNP antibody levels correlate with disease severity. And actually, antibody positivity correlating with disease severity is at this point limited to only a few antibodies where we really recommend testing for monitoring. I'd say an example of this is double-stranded DNA antibodies, but I am not aware of any current recommendations to serially monitor for RNP antibodies.
Great, thank you. All right, another question here. What is the youngest age we've seen with MCTD?
I have to apologize. As a laboratorian and a PhD by training, I don't see patients, and so I do not know the exact answer to that question, but I can try and look into it and get back to you.
Perfect, thank you. All right, and I want to thank our audience for all these great questions. We do have time for a few more, so we'll continue. This next question I have for you asks, did you encounter some cases considered as an exception to the proposed criteria, especially the laboratory ones?
Again, where I'm not a clinician, I can't say that I have run into too many that have been exceptions. I think the biggest challenge right now in trying to apply any of the laboratory criteria is that many of them were established using older methodologies, such as immunodiffusion or hemagglutination. And so really, I think the biggest challenge right now is trying to figure out what constitutes a high titer or a high positive RNP or Smith RNP antibody level using the current methods. And that's something that we really need some good studies to help us establish. That is why I've suggested using some other testing, such as ANA by IFA, to help in correlation with the RNP antibody levels, because there have been a lot of efforts to standardize interpretation of ANA by IFA.
Great, thank you. All right, now what would you recommend for an antibody panel? Anti-RNP and anti-SMRNP, or anti-RNP, or anti-RNP, SMRNP, and anti-Smith?
Personally, the panel I prefer is the anti-SMRNP and anti-Smith. That will help you to distinguish between patients that have anti-Smith, which depending on the clinical symptoms, could be consistent with a diagnosis of lupus, or to identify patients who are positive for Smith RNP, but either negative, low positive, or kind of borderline for Smith, which would be more consistent with a diagnosis of mixed connective tissue disease. Again, the results should always be interpreted in the clinical context.
Thank you. All right. Now, if a lab only tests for Smith RNP and not RNP, what diagnosis might you be missing?
I think that is something that we still don't know. We aren't sure about what those antibodies against the RNP specific protein that are not also positive using assays, positive for Smith RNP, are actually indicative of, or what their clinical utility is. In our study, 2/3 of the patients that were positive for antibodies against the RNP specific proteins 68 and A had no clinical indications of a connective tissue disease. One had catastrophic antiphospholipid syndrome. I think one had seronegative rheumatoid arthritis, and one had sarcoidosis. But the rest of them, which was the vast majority of those samples, we did not see any signs of autoimmunity in the follow-up period from the time the testing was done to the chart review. And so at this point, we really need more studies to know if we are missing something by not using those RNP-specific proteins.
Great, thank you. All right, next question here. Could low anti-RNP positive results, especially when only anti-RNP positive, be caused by viral or bacterial infections rather than autoimmune diseases?
I think it's possible, but we don't have the data at this point to answer that directly.
Great, thank you. And again, I want to thank our audience for all these great questions. We do have a few more minutes and time for a few more questions, so we'll wrap up soon here. But this next question asks, would you recommend automatically reflexing positive ANA patterns to ENA profiles and vice versa if not already done?
I think the answer to that question is a difficult one. At my specific laboratory, we offer multiple ways of doing that. I always think the best way to order testing is based on clinical suspicion, but I recognize that there are scenarios where it's similar to what we've talked about today, where there are patients that may have symptoms that can be associated with multiple different rheumatologic diseases and or the presence of different antibodies. And so, personally, I like to offer panels where you can do either, where you can just order the ANA by IFA and then follow-up testing based on your clinical suspicion, but also to have panels available where it can reflex based on the ANA IFA pattern.
Great, thank you. All right, moving on, this next question asks, did anti-CCP positive have any significance in the diagnosis?
I am not aware of studies showing a significance for anti-CCP, and I can definitely say we did not evaluate that specifically in our study, and it did not come up frequently in those patients who were positive. I would have to go back and see if any of them were CCP positive. I do know the one patient had seronegative RA and was negative for CCP antibodies as well as rheumatoid factor. However, that patient was positive for antibodies against the RNP specific proteins, but not positive using the assay against Smith and RNP antibodies.
Great, thank you. All right, well, looks like we have time for one more question here, so we'll wrap up after this one. This final question asks, does all low anti-RNP titer results need to be confirmed by different methods?
I would say yes. At this point, if it's an RNP specific protein that's used as the antigen, that in order to consider that associated with mixed connective tissue disease, you would need to either have a high titer speckled ANA pattern or a high titer or at least positive anti-Smith RNP.
Great. All right, well, thank you so much, Dr. Peterson. That will conclude our session for today. Do you have any final comments for our audience?
I would just like to thank everyone for joining us today and to thank you so much for so many great questions. I think this has been one of the question and answer sessions that I've participated in, which has had the most questions asked by the audience. So I'm really enthused by the audience participation, and I hope that I'll get to meet some of you at an upcoming meeting and discuss this further, and really, look forward to working with some of you on addressing some of these issues in the future.
Absolutely. Well, thank you again, Dr. Lisa Peterson, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Bio-Rad Laboratories, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share